Hello, everyone. Welcome to this webinar on strengthening the monitoring and evaluation of COVID-19 prevention programs. My name is Erin Palomares, and I work with the Global Hand Washing Partnership Secretariat. Before we get started, I'd just like to go over a few housekeeping rules. So first, as a participant, you will be muted throughout this webinar. However, we highly encourage you to interact through the chat function and talk through your experiences or challenges with M&E. We'll also have some time for a Q&A at the end of our presentation. So if you have a specific question to a speaker, please use the Q&A function. And that function should be right next to the chat on your screen at the bottom of your screen. And lastly, this webinar is being recorded. So the recording and the summary will be available in the next day or so. So please do share that with any colleagues who were not able to attend today. Next slide, please. So this webinar is co-convened by the COVID-19 Hygiene Hub, the Global Hand Washing Partnership, and the Global Wash Cluster. And this slide just provides some details on each of those organizations. I have to say we're really excited to collaborate with these two organizations who bring a wealth of expertise and are especially excited to share some lessons learned and, more importantly, share some examples of M&E best practices. Next slide. So on this slide, you'll see just an overview of today's webinar. First, we'll provide an overview of the learning brief this webinar is based on, and then we'll have 3 case studies from AMREF, WaterAid, and the Norwegian Refugee Council. And again, we'll have some time for Q&A after these presentations. So with that, I will turn it over to our first speaker, Sean White, the response lead at the COVID-19 Hygiene Hub, who will give an overview of the learning brief that was just published. Over to you, Sean.
Thanks very much, Erin, and good morning or good afternoon to everyone. Thank you so much for joining wherever you're joining us from. Please do feel free to introduce yourself in the chat, which is great. I can see all those comments already coming in. Looking forward to finding out who's online. If we can go to the next slide, please. So today's webinar is going to be based on a learning brief that was recently published on the COVID-19 Hygiene Hub. And I wanted to start by just sharing a little bit about how the information in this brief was compiled. So as some of you may know, the COVID-19 Hygiene Hub was set up in April last year in response to the pandemic. As kind of briefly mentioned on the previous slide, we provide 3 different services. So you can see these displayed on the top of this slide. But this learning brief and this webinar really build on a range of formal and informal ways that we've been learning from frontline staff over the course of the last 16 months about their pandemic experiences. So, for example, the Hygiene Hub has developed over 200 resources, which are now available in English, French, Spanish, and Arabic, and they've been really widely read and shared. And so it's been useful to gauge people's reactions to those and modify them as we've gone along. We've also been providing rapid support to more than 150 organizations around the world through our online service, which allows you to chat in real time with a technical advisor. We also provide in-depth collaboration and support to more than 50 initiatives globally, and this has kind of allowed us to learn with partners. And then on our website, you can find an interactive map, which includes information about 285 COVID-19 response projects. And then if you go to our case studies tab, you'll also find some in-depth examples of what's been working during the pandemic and also reflections on common challenges. The last thing that we've been doing is we've tried to be doing some active learning from COVID-19 response actors. So we've conducted more than 80 interviews with people all around the world to really understand how programs are being designed during this very unique period of time. And so the brief really brings together all of these different types of learning. And we also look forward to, at the end of this session, learning from all of you about your experiences during the question and answer part of today's session. So if we go to the next slide, please. Great. So to give you a quick overview of the learning brief, I would encourage you all to have a look at this. I think the team at the GHP are going to post a link in the chat, but it's full of lots of examples of practical tips in addition to what we are covering in this webinar. So in this first session, we're going to go over how M&E approaches have changed over the course of the pandemic and what are some of the common challenges that people have been facing. We're then going to focus on what we have learned about common approaches to monitoring, and then we're going to wrap up by talking about ways of assessing programmatic impact during the pandemic. And then I'll hand over to our really exciting case studies who are going to be sharing more about their specific work that they've been doing. So next slide, please. Great. So in the early phase of the pandemic, this was really, I'm sure, as you can all remember, characterized by a lot of uncertainty, and many actors that we engaged with reported that, unfortunately, M&E had often been deprioritized, it had been put on hold, or it had just simply been overlooked. And this was often compounded by the fact that staff were being asked to focus on critical, life-saving type tasks and minimize their interactions with populations where possible. And so what this often meant was that M&E staff were unable to travel to programmatic locations to do even rapid assessments. There was also a lot of novel aspects to the response at this point in time, and it meant that our lessons learned from prior experience were not always transferable to this pandemic. And this was because we were often needing to measure new types of behavior in new settings, a lot more focus on public settings, for example, and assess the impact of new types of delivery channels, a lot more people sort of working with social and mass media during the pandemic. At the beginning of the pandemic, I think there was also a common belief that COVID-19 would be relatively short-lived, and so it wouldn't be too much of a compromise if M&E was not a focus. And I think, obviously hindsight has proved that that was definitely perhaps a shortfall of programming. In the early phase, there was also a lack of global guidance about how to do M&E in a way that would keep staff and population safe, but still allow that data to be collected. Next slide, please. While many organizations tried to pivot towards remote data collection, this wasn't always an easy thing to do. Remote data collection was unfamiliar to many organizations, and so people struggled not to just, firstly, to skill up in terms of becoming familiar with the new technologies that this required, but also in terms of understanding how standard methods would need to be adapted for these new technologies and remote ways of learning. And data collection processes were often hampered by the fact that many organizations did not have pre-existing lists that allowed them to contact people within the population. So, for example, lists of phone numbers that would allow them to do a phone-based survey, for example. So this process of building those connections actually took quite a lot of time in and of itself. And as in many crises and outbreaks that we've seen in the past, most programs tended to focus their M&E activities around tracking reach. So what I mean here is tracking, for example, the number of hygiene kits that were distributed, or tracking the number of radio announcements that were made. And these kinds of metrics are the kind of go-to because they're relatively quick and easy to roll out. However, most organizations struggled a lot more to include measures that focused on acceptability or outputs or outcomes. These were much harder to measure. In some countries, data collection during this phase became quite sensitive as well, and also politicized. And so some organizations faced restrictions on what information they could collect and how they could use it and how it was shared. And so this was quite problematic and stalled a lot of programmatic activities as well. And lastly, for those who were engaging in operational research initiatives during this time, we heard quite often that many organizations encountered barriers as they sought ethical approvals from local review boards. And this wasn't so much to do with the specific ethical issues that arose, but much more to do with the standardized processes that these ethic review boards take. And these were not always able to be expedited to allow rapid learning around the response. So this is perhaps an area to improve for future response. Next slide, please. So as we moved into the protracted phase, it's probably no surprise to any of you that one of the key learnings here was that often M&E approaches had to be delayed, they had to be adapted quite a lot from what was initially proposed, and I'm sure all of you have experienced those kinds of challenges. One interesting finding that we learned from response actors was that actually quite a lot of in-person data collection did continue throughout the pandemic. However, this was not always based, this decision to go back to in-person data collection wasn't always based on thorough risk assessments, but rather on what was feasible and familiar and just possible to do. However, we did start to see some nice examples of organizations developing phased plans that outlined how their programmatic and M&E activities would be adjusted to be aligned with national guidelines and patterns of transmission should they change in the future. So that kind of adaptive programming was really nice to see. And in this protracted phase, we also saw organizations realizing how important monitoring systems were going to be to guide their adaptive response. So many organizations at this point started to realize that actually one of the most difficult aspects was that the tools that they've developed weren't necessarily particularly well suited to allow for programmatic adaptation. So I think, again, thinking about how these insights can influence future programming, we often overlook this translation of findings to programmatic improvements. And this is an area I think we do need to strengthen. Next slide. In the, also on the protracted phase, we noticed that in some countries, we did start to see fatigue arising among populations in relation to M&E. And also we did start to see in some countries that data collectors were being treated with suspicion and even in some cases being directly attacked verbally and physically. And sometimes this was because they were viewed as people who might contribute to the spread of COVID-19 transmission. And this was because they were still moving around in communities to facilitate learning. But I think more commonly, it was often due to misperceptions about what their role was and how this related to health services. So quite often people were concerned that the M&E team might divulge personal information or that the information that they shared with them could cause them to have to go into self-isolation, which understandably people wanted to avoid. Next slide, please. Great. So while a lot of what I've just outlined focuses on common challenges, I'm hoping to do this in the hope of highlighting areas for future improvement within programming, not just within the continued COVID-19 response, but also in terms of preparing ourselves for future outbreaks or crises that may occur. And in our discussions with frontline staff, they flagged several broader issues about the nature of the pandemic that ended up affecting the way that M&E decisions get made. So firstly, they mentioned that the pandemic was quite unique because it was rare that all of the response staff globally were directly affected and were also at risk because of the crisis. And furthermore, the new ways of working that we developed over the course of the pandemic often meant that support staff or those based in headquarters were much more limited in the kinds of support that they were able to provide. And so while there was some positives around the role shifting that occurred, it often increased quite a lot of pressure onto frontline staff who were also at greatest risk. So I think going forward, there's some real questions that we need to think about in terms of prioritizing duty of care to staff and staff well-being. Secondly, many organizations reported that their relationships with donors had a significant bearing on their work during this time. And in particular, those who managed to establish open and frank dialogues with their donors were more able to update them in real time about the local situation, which often allowed for greater flexibility to be built into their programs and also their donor and contractual expectations. And lastly, and perhaps unsurprisingly, those organizations with weaker M&E systems prior to the pandemic did struggle more to adapt to these circumstances. And I think this really speaks to the need to invest in M&E capacity strengthening in order to support preparedness for future outbreaks or crises. And there's a real need for organizations to share experiences as we're doing today, and for coordination mechanisms to facilitate this capacity strengthening through a range of initiatives. Next slide, please. So I'm going to move on now to talking about specific lessons we've learned in relation to common types of data collection. So as I mentioned before, in-person data collection was actually quite common during the pandemic. And one positive of this was that most organizations did eventually start to develop their own guidance around the requirements for safe in-person data collection. And pleasingly, there was some kind of consensus that we see across these and between organizations and countries. So if you do go to the learning brief, please do have a look at this section. We detail a full list of practical tips for doing in-person data collection safely, whether that's interviews or larger group discussions. Next slide, please. So moving on to remote data collection. Now, obviously, remote data collection became much more commonplace during the pandemic. And I think this meant that there was a steep learning curve in this space. And ultimately, many of the organizations that we spoke with saw clear positives from this remote way of working. So one example of this was that it made data collection much more efficient, allowing more interviews to be done per day and across a much more diverse geography because we no longer had to factor in travel time. Others said that their experience with remote data collection was something that was likely to kind of carry on within their organization and that they may continue to include this within their longer term work. Interestingly, some humanitarian actors were much more well placed to kind of pivot towards remote data collection. And this was because sometimes they had mechanisms in place to collaborate with communities on occasions where security did not permit in-person work. Having said this, this didn't necessarily translate across the board. So for example, you might think that organizations with prior experience in responding to Ebola or cholera outbreaks would have been quite well placed when this pandemic came along. However, often remote M&E approaches weren't really used during these prior outbreaks, given that these diseases weren't airborne and therefore the in-person sort of work was still allowed to go ahead. A range of remote data collection actually took place over the course of the pandemic, according to the experiences we heard. And this included using phone-based interviews, SMS surveys, IVR, which is interactive voice response surveys, or social media polls. However, as we kind of shifted to these modalities, it also meant that often questionnaires had to be a lot shorter, given limited attention spans that these formats allow. And this meant that data was predominantly quantitative in nature. And sometimes by the end of the data collection period, we realized that we didn't always have the kind of full story, which sometimes prevented some areas of programmatic adaptation. Others who used methods like random digit dialing or social media polls often struggled because the population that they were sampling and getting feedback from didn't necessarily map on to the literal target population that they were working with on the ground. And so drawing conclusions between those who responded to their M&E methods and those who were receiving their programming was a little bit tricky. One thing that seemed to work quite well for organizations was repeated rounds of data collection with the same cohort of people. And this allowed for organizations to develop much better rapport with participants and to see how behaviors and perceptions were changing over time. Next slide, please. So despite most of data collection during the pandemic being quantitative, there was some really nice examples of qualitative remote learning as well. So organizations that used qualitative methods or combined these with quantitative approaches often found that this kind of gave them richer information to work from and to therefore made it easier to translate findings into programmatic adaptations. So I wanted to give you 3 examples of qualitative learning, and these are all included in the brief itself. And the first comes from Gramvani in India, who invited community members to use their mobiles and an IVR system to record voice messages about their pandemic experiences. And these stories allowed them to adapt programs in real time, advocate on behalf of populations really effectively, and also allowed individuals in one community to share their experiences with other neighboring communities so that people felt connected during the pandemic. The second example is from GOL in Honduras, and they organized video-based remote focus group discussions. And to facilitate this, they made sure that participants were given data credit in advance so that it wasn't at a cost to them. One thing that I really liked about this approach is that they didn't want the use of technology to become a barrier for certain key groups. So for example, they invited older people and people with disabilities to kind of buddy up with younger family members so that they could be part of the discussions, which I thought was a really nice idea. Lastly, in Malaysia, ANAC wanted to engage and learn from quite hard to reach undocumented migrants. And they found that WhatsApp was a really effective way of reaching them. And so they invited participants to do a photo journal of their daily life during the pandemic. So this involved participants sharing images of what they were doing to prevent COVID with a short narrative description. So for example, the image you can see here on this slide is an outdoor sink built by a participant during the pandemic to facilitate hygiene as they came in and out of the house. So these are just some examples of kind of creative learning experiences during the pandemic. Next slide, please. So moving on to phone-based data collection, since this kind of became such a key part of data collection during the pandemic, and also something that was relatively new for many actors. So we wanted to share some practical tips that have kind of emerged from the various experiences of different organizations. The first is one of the challenges of working with phones in low and middle income countries is that, of course, you're likely to encounter network issues, power outages, issues with phone charging and phone credit. And so organizations had to get creative about how they kind of problem solve this. I don't think it's possible to overcome it entirely, but we did see organizations trying to change the times when they called people. So different times of the day, sometimes even utilizing weekends if people were more available then. And we also saw people notifying people in advance of their calls. So people would send an SMS saying you'll be called at this particular time so that participants can know when to have the phone available and when to have it fully charged. It's also obviously a lot harder to maintain a person's attention during a phone-based interview or survey. And so another tip that we learned was that it can be useful to ask different types of questions over the course of your interview or survey. So for example, you could ask a normative question about the behaviors of others in the community. And this could be followed perhaps by a scenario-based question, which might get people to imagine that they were in a particular situation and ask how they would respond. Otherwise, you can use different types of answer responses. You can have open answers, but you could also have a scale, for example, to learn about things in different types of ways, and this should help keep attention throughout. Obviously, phone access in low and middle income countries is also not always equitable, meaning that sometimes you might find that men have more access to phones than women, or that older people and people with disabilities are less likely to have phone access. And one tip that we picked up was that it's quite useful to, when you've got your sampling completed for your COVID-19 work, it's quite useful to compare the demographics of that survey with a survey that was undertaken face-to-face to see how much this kind of the need for a phone has affected participation in your actual survey. And then you can identify whether additional approaches might be needed in order to reach certain subgroups of the population. Building rapport with participants is also, of course, much more difficult over the phone. As I mentioned before, repeating interviews with a cohort of participants is one way of overcoming this, but it also can be useful to match the gender of the interviewing staff with participants and to train data collection staff on good listening skills so that they can be responsive to what participants say. And lastly, data collectors may be the first people to often hear when misperceptions around COVID-19 arise as in the course of their data collection. And so several organizations have started to provide staff with messages that they can pass along to participants at the end of interviews if they notice that misperceptions have been expressed or if they think the person might benefit from available services. And doing this at the end of interviews means that information is not likely to bias the interview process. Next slide, please. So often we tend to think about M&E as kind of a separate process done by dedicated M&E or MEAL staff and not part of our programming. And I think the pandemic has created a situation where there's a real risk that the kind of anecdotal or informal interactions that we might normally have around a program, that they get missed or deprioritized. But actually, it's often when we've been speaking with people, these anecdotal and informal ways of learning that have been really key to making sure our programs stay current and are responsive to the situation on the ground. So again, we've compiled a few tips that strengthen this kind of routine learning. So firstly, we had some great examples of maximizing existing data to inform programming. And this was particularly important during the acute phase of the response, where the opportunity for new data collection was quite limited. So for example, in Zambia, Grid 3 worked with the national government to develop a thing called the Zambia Data Hub. And this used existing national data about water availability, population density, and various other factors to kind of create geospatial risk maps, which really helped actors prioritize, which areas of the country they should prioritize within the response. Secondly, as staff shifted towards remote working, there was a real risk, as I said, that on-the-job learning might be lost, and that there would be fewer opportunities to reflect on programming as a team and make improvements. So, for example, in Zimbabwe, ACF was using a tool called the Community Perception Tracker to understand how perceptions shifted over the course of the pandemic. And what they realized was that this tool could be really enhanced by having regular meetings with all of the program and data collection team, and also establishing a WhatsApp chat to share experiences in real time. And they also gradually modified their standard reporting templates to ensure that the richness of these discussions could be adequately captured and shared. So really, this is about modifying the way and structuring the ways that we do our standardized ways of working, so that we can use that data to influence learning. In many countries, organizations also found it quite critical to establish a network of community stakeholders who, again, they can connect with in real time to understand how the situation is changing. So this could involve like community leaders, religious leaders, women's groups, and various others. But these networks were really key in obviously improving programming, but also increasing local ownership and making other kinds of M&E approaches more acceptable. Lastly, we've all heard people talk about the challenges of the infodemic, and of course, program staff are often equally overwhelmed by all of the information that they're receiving by email and the general information about the pandemic. And for this reason, our traditional approaches to sharing and dissemination of results are often becoming less successful during the pandemic. And this is because people simply don't have time to read really long reports. One nice example was from Bangladesh, where they tried to summarize some of their qualitative findings through cartoons, which described real stories that they had heard. And this kind of made their results stand out and be easy to digest for a range of different actors. We've also seen organizations making the most of free online design tools to help improve the visual layout of the reports they are developing. Next slide, please. So we want to shift gears now a little bit and move away from monitoring, and just wrap up by talking a little bit about how we can measure impact and why this is challenging a little bit during the pandemic. So as many of you probably recognize, measuring impact was particularly challenging during the pandemic. And this was because there were multiple factors affecting transmission of the virus, and there were limitations in regards to the reporting of cases and deaths. So we couldn't necessarily rely on health-based data as a measure of impact. We also often had, we lacked reliable estimates of behavior from prior to the pandemic that would allow us to make a point of comparison. And there were also many actors undertaking response initiatives. And so in any one setting, people would have been exposed to more than one programming. And this made it quite hard for any one actor to kind of understand the contribution of their program specifically. At the same time, of course, we had fewer tools at our disposal, and a lot of our higher quality impact measures of behavior, for example, extended household observation, these things were typically deemed as unsafe. And so we had to shift the way that we thought about measuring impact as well. Next slide, please. So just wrapping up then, we do have some suggestions that of creative approaches that were used to overcome some of those limitations when it comes to measuring impact. This included the use of a theory of change, and theories of change, for those of you who are less familiar, describe how a project proposes to build about a change in behavior or health outcomes by outlining a step-by-step causal chain of events. And normally these are used for program design, but they're also really useful for monitoring too, because you can develop indicators and data collection methods that track each stage in this causal chain, and that will help you understand whether your program worked and why. Secondly, given that M&E approaches have often have to be adapted, people found it very useful to include more than one impact measure. So for example, including more than one way of measuring behavior, so that if certain methods have to be dropped or changed, you've still got something to go on. Thirdly, while measuring impact is challenging at the moment, there were a lot of other outcome measures that are really vital ways of understanding program performance that are quite easy to measure, but are often overlooked. And these include things like making sure we assess program acceptability, program relevance, and the sustainability of programs. And lastly, as I mentioned on the previous slide, it's currently very difficult to attribute change to any one organization because everyone's been exposed to multiple government, organizational, and community-led initiatives. So given this, it gives us a really great opportunity to try and do joint evaluations where possible with other actors working in the same area as you, and then really trying to evaluate the overall nature of the response and how these programs have interacted with each other. So last slide, please. So I'm going to wrap up my part of today's webinar there. I haven't presented sections that are in the brief that relate to survey design and observational methods. I do encourage you to have a look at these, but the reason I haven't presented them today is because we're about to jump into our case studies, and these are going to focus on these particular elements. So we're going to hear a lot more from our exciting case study presenters. Thank you.
Thanks, Sean. Yeah, some really, really interesting insights included in that brief, and I'm certain this brief will serve as a helpful tool as we look to strengthen our approaches in future learning. We have posted the link to the full brief in the chat, so I encourage everyone to take a look at that when you get the chance. But like Sean said, we'll now shift into some examples that are also highlighted in the learning brief. So first up, we have Mr. Dennis Munai, a project manager at Amrath Health Africa, and he'll be presenting on monitoring hand washing facilities in public spaces. So over to you, Dennis.
Thank you, Arian. I think the next slide, please. So as mentioned, my name is Dennis Munai. I currently work at Amrath Health Africa in Kenya. I'll be presenting about monitoring hand washing facilities in public spaces. So this is an initiative that we conducted together with the National Business Compact on Coronavirus. And this was funded by the UK Aid and Unilever through the Hygiene Behavior Change Coalition project. Thank you so much. Next slide. So as mentioned, this work was largely conducted under an umbrella of partners under the National Business Compact on Coronavirus in Kenya. And these were largely hygiene businesses, private sector alliances, the UN bodies and the NGOs in the country that got together to implement and accelerate local action for COVID-19 intervention in the country. During the start of the pandemic, that was in March last year of 2020, the government mapped out what they called hotspots in the country. These were places that they thought would mostly be classified as hotspots for COVID-19 transmissions. And out of this, there was supposed to be some initiative or measures to ensure that COVID-19 is the spread of COVID-19 is limited. So out of the 7,000 plus hotspots, NBCC distributed 5,311 hand washing stations, and this was across the country. The distribution was conducted across 3 months. Of course, again, as the pandemic progressed, many other partners joined in the initiatives, and there was many hand washing stations that were distributed across the country. So with this came in a challenge for monitoring and evaluating these hand washing stations, basically just looking at their functionality, the use, usability, issues around operation and maintenance, especially since no work had ever been done across the country to just check on these hand washing stations. Next slide. So with the NBCC partners, the 5,000 plus hand washing stations that were distributed, the partners kept an inventory of all the hand washing stations that were being distributed, and we used to have weekly check-ins through a technical working group, just to check on the monitoring aspects of the hand washing stations that were being distributed. Just looking at one, are they being used? What about issues around soaps, the water, are the taps working very well? And some of the routine data that we collected was looking at around usage, random spot checks, self-reporting data. At some point we employed sensors, and all these data we kept on presenting this data and looking at how we can best use this data moving forward as we kept on implementing and distributing these hand washing stations. So some of the data that we're looking at, indicators included hand washes, issues around water and soap, are they being used, issues around user types, were they new versus repeat users, demographics and locations. And the data that we collected, either we used that to inform decisions, either change places where we were distributing these hand washing stations, supporting issues around ensuring that there is soap wherever it is needed. And of course, these data kept on being used by partners and the government to look at sustainability measures, issues around location and the likes. But we realized that this monitoring data was not enough because there were issues around reliability. So we decided to undertake an evaluation, a rapid evaluation, just to learn from the data that was coming out on what measures need to be changed or what needs to be done to ensure that there is sustainability issues are checked, usage is checked, and issues around functionality. Next slide. So for the evaluation, we conducted a rapid evaluation, and this was it was mixed data collection method, and this was across. We chose five diverse counties in the country, and this was Nairobi, Embu, Kwale, Mombasa, and the western part, that is Homa Bay. And the objectives was, one, to check functionality, stability, and maintenance, to look at the barriers, enablers, and basically to look at sustainability gaps for effective hand washing in public spaces. Next slide. So I'm going to, the mixed methods, we looked at quantitative, we used quantitative methods for data collection and qualitative. So spot checks, caretaker surveys, user observation, and user exit surveys. We also had key informant interviews via phone, and of course FGDs, but these were in persons. So the quantitative methods mostly were in persons. Qualitative methods was mixed, phones and FGDs. For the in-person data collection, we used enumerators, but we ensure that all COVID-19 safety measures were being observed. The next slide. I'm going to now talk about some of the key findings around functionality presented there. So these are summarized. So looking at functionality, 84% of the hand washing stations were functional. Issues around maintenance, close to 80% of these hand washing stations had caretakers. So meaning that the operation and maintenance at least was manned. Issues around functionality, accessibility, and use. The worrying part is that half of these hand washing stations could not mostly reached by persons with disabilities, people on wheelchairs, which was a little bit something that we changed to ensure that inclusivity is assured. So next slide. So in terms of the lessons learned during the evaluation, we realized that the observation time that we took was a little bit limited. So we thought that it is important to increase, because we only observed hand washing stations for 30 minutes within a day. So we thought that was a little bit limiting. We also realized that there are different dynamics across public spaces. So marketplaces present different challenges compared to churches. We also realized that we did not collect data from non-users. So the data that we collected was only from users. And these again limited our research findings. On issues around the exit interviews, it is important to keep it short and precise. People are busy and people want to undertake their daily tasks. There are some questions that we thought when we did not present meanings. So issues around maybe water level, it doesn't really matter, because the water that is there should be sufficient. Issues around the public settings. So there are certain spaces that, for example, in a rural shopping center, you'd find that the hand washing station in the morning, people are out there in their farms or in their homes. It's only in the evening that they come to the shopping centers or around lunchtime. So sometimes we missed out on that data, on collecting that data, because we didn't factor this during data collection. And issues around the distance for that because these were covert operations. So that also at least helped us to look at good data that was not corrupted. So next slide. So I'm going to summarize again some of the enablers that we found and some of the barriers. Issues around, so as enablers, the fact that we worked with government and targeted the hotspot areas, so was a plus for us. The government had a running campaign, which was really good, that it ensured that people wash their hands. Issues around design features that we kept on adapting. The fact that we worked with community infrastructure, community health units, and the community infrastructure was a plus. In terms of barriers, I think the biggest one was around inclusivity. People with wheelchairs could not access half of these hand washing stations. Again, the other component was around the size of the containers. We kept on changing the size of the containers from 20 liters to 100 liter, just to help out with the refill. But also there were issues around drainage system that we had to change and adapt as we moved on. The other bit was around the hand washing commodities. So again, we found that this was a big factor in regards to sustainability and continuous functionality of these hand washing stations. So I think other than that, that is what we learned from the research. Thank you so much.
Great, thanks so much, Dennis. And I have to say, it's great to see the efforts around hand hygiene in public spaces. I know COVID-19 has really showcased the importance to address hand hygiene in these spaces. So glad to see those efforts happening. I also find it interesting that you leverage some in-person data collection, and hopefully we can get more into that decision-making later on. But for now, we could just move on to the next slide, please. So moving to our next speaker, we have Dr. Om Prasad Gautam, the hygiene lead at WaterAid, who will be presenting on a recent multi-country survey that they conducted. So over to you, Om.
Thank you, Ariane. Thank you, everyone. Hi, everyone. Good afternoon. And also good morning, good evening, wherever you are. My presentation will be based on our multi-country midterm rapid assessment survey conducted in 8 countries, particularly focusing on COVID preventive behaviors. Next slide, please. Since the beginning of the pandemic, WaterAid as an organization, we have positioned hygiene as first line of defense to COVID-19 and continuously prioritize our hygiene response in 26 countries. Among those 26 countries, 12 of our country program actually implemented response at large scale, at national scale, and some of which also includes funding from SBCC, which is a FCDO and Unilever coalition initiative. Through those hygiene response to COVID-19, we were targeting to reach 99 million population within 1 year. And those responses actually focusing on 5 key preventive behaviors, COVID preventive behaviors, including hand washing with soap, wearing a mask, maintaining physical distancing. And we have used a very simplified version of the behavior center design approach in order to design the hygiene intervention based on evidence through a creative process and implementation, maintaining fidelity, and also monitoring in order to assess the effectiveness. Our regular reporting shows that our hygiene response to COVID-19 delivered through mass media, social media, non-contact methods, as well as community-based intervention were implemented, reached 181 million population all across 26 countries. We have also installed 2,700 public hand washing facilities. Those are mostly inclusive, paddle operated, primarily semi-permanent and some permanent hand washing facilities. Because for behavior change, we know only the promotional aspects and the facilities are not enough. So in order to reinforce the behavior, we need visual cues, nudges, and reminders. That was also part of the intervention. And also we have distributed 1.8 million hygiene products all across many countries, primarily for the public hand washing facilities, as well as for people, those are very marginalized, residing in a very marginalized communities. Our hygiene response to COVID-19 also has elements of sector coordination. Our country, where we're operating, we're also supporting to the national government through wash clusters, health clusters, and also we're part of the different global initiatives, including the Hand Hygiene Fall initiatives. So it was a massive, large-scale hygiene response to COVID-19 all across 26 countries. Next slide, please. Because we have responded COVID-19 all across 26 countries, at the beginning when we started responding it, we didn't set up a baseline because it was like a rush intervention. There was no time for us to set up a baseline because we have used the earlier evidence to inform our program design. So without baseline, we actually started responding it. But as a credible organization, also long history implementing behavior change programming into the sector, we started realizing we need a real-time data set to inform our ongoing programming because some of those behaviors, including wearing masks, maintaining physical distancing, were new. So we really needed a real-time data. At the same time, because we have invested a lot in 26 countries, we needed to know how well we are responding to COVID-19. So therefore, institutionally, at the middle of the pandemic, as soon as we started implementing it, we then started thinking, okay, let's do a midterm rapid assessment at the middle of the response when we are actually implementing in 8 countries. We have selected 8 countries. Those includes, those are basically the 31% of our overall programmatic countries in Asia and African settings. So out of 26 countries, 8 countries were selected for the midterm rapid assessment. Through the assessment, we really wanted to assess the effect of the intervention and then also the outcome related to our response to COVID-19. The assessment was primarily trying to assess the prevalence hygiene knowledge, behavior, and social norms related to COVID-19. We're also trying to assess the key motivational drivers and existing barriers. By way of assessing these, we really wanted to address some of the barriers and existing motives in order to make our program responsive. And then because we are delivering using multiple delivery channels, we also wanted to know whether the delivery channel are actually effective and reaching to the people. So assessing the preferred delivery channel as well. So we have also assessed the functionality of hand washing facility, but I'm not going to focus on those aspects part of this presentation. So primarily on the behavioral aspects of these survey will be presented. Next slide, please. The assessment, the midterm rapid assessment, was cross-sectional in nature. We have implemented in 8 countries at the same time, October, November time last year, and data were collected within 15 days all across all the countries. It was predominantly quantitative survey because collecting qualitative information, conducting conducting focus group discussions and structure observation, all of this were not possible in the middle of the pandemic. And then the data were collected in what were implementing areas. We have used a range of methods to collect the data. Primarily for the survey, we have used household survey, which is a structured questionnaire survey. And we have done that in 3,500 households in 8 countries. And for hand washing facilities, we have used a spot check and key informant interview that was not part of this intervention. So the key, how did we do that? What process we have established? Because it was a multi-country initiative, we really wanted to standardize tools and methods. So what we have done at the beginning of these initiatives, we standardize the tools and methods, working with the London School of Hygiene and Tropical Medicine Hygiene Hub. We really wanted to standardize. Standardization has lots of implication in terms of positive implication. I'll highlight some of those subsequently. Data were collected in person using mobile phone, but at the same time, we have used Yum Water platforms to enter electronically so that there is kind of data check-in as we enter and collect the data. Data analysis preliminarily was done by Waterway internally because we really wanted to see the data and make our ongoing hygiene response more progressive. But at the same time, we wanted to have the third-party view and some statistical analysis. Therefore, work with London School Hygiene Hub and Rana's colleagues to further analyze the data. There are limitations of this survey because we really wanted to understand the contribution that Waterway making rather than the attribution. As previous colleagues mentioned, because the delivery channel for hygiene response to COVID-19 were mainly mass media and social media and digital. For many of the organization, the people might have contaminated from different interventions. So therefore, for Waterway, differentiating was quite difficult. So therefore, in an area where we are implementing, we really wanted to see our contribution. The data we are collecting were representative to the districts or regions where we have collected rather than national representation. And I mean, ideally, we wanted to conduct the structure observation and focus group discussion, but that wasn't possible because sitting in a household for long hours wasn't possible throughout the pandemic. So therefore, we have to skip the structure observation. Next slide, please. So while designing data tools, data collection tools, we are very much prescriptive that we wanted to focus on knowledge, reported behaviors, and social norms because we needed this information in order to make our program progressive. At the same time, we wanted to see whether people are actually aware about these behaviors. If you look at the data, all occurs multiple behaviors, 4 behaviors. The intervention has actually managed to improve the level of awareness, and the people reported that they are currently practicing the behavior. And we have also asked whether those changes were due to the intervention. Of course, you know the limitation of the reported behavior. So therefore, we really wanted to assess whether that exists among multiple people. What about the social norms? Do people think their villagers are actually practicing these behaviors? If you look at these data all across, around 50% people believe that others are performing the behavior are due to this intervention. But we are very much prescriptive when you look at the specific time slot for specific behaviors and looking subset of the behavior when it comes to data collection and analyzing. For example, hand washing with soap, though hand washing with soap is a main focused behavior. If you look at the data, the after defecation and before eating, the level of awareness and reported behavior were quite high. But at the same time, when we collected data, we were collecting the data for the COVID-sensitive critical time for hand washing. If you look at those moments, were pretty much low during the midterm survey. So it actually gives an indication that our second phase of the intervention needed to focus on those critical points rather than the ritual normal hand washing facility critical moments, right? So hand washing critical moments. So social norms also give us lots of indication where to focus and where to emphasize our ongoing intervention. Next slide, please. So throughout the intervention, we are also looking at what were the barriers, or what were the motives. Just very much prescriptively on these motives. We know that since the beginning of the pandemic, fear is going to be one of the temporary stimulus for people to change the behavior. So therefore, we're primarily focusing on multiple behaviors part of our intervention. And through this assessment, we wanted to see what is the prime motivational driver for people to practice the behavior. If you look at this, fear is one of them, but not only the motivational drivers. So collecting multiple motivational drivers, but whether motivational drivers actually use in order to motivate people to practice these behavior was quite key. So therefore, the second phase of our campaign is actually focusing on multiple motives rather than only one. Finally, next slide, please. Finally, what I would like to sum up here is the learning based on methodology that we have used and the programmatic learning. Methodologically, because we have standardized tools and methods, it was easy for country to contextualize, replicate. And when you analyze data centrally, it was also helpful for cross comparability of these data. Because we were curating large amount of data set. It was, I mean, the information here, it is possible to collect large data, but we need to take a conscious effort here. It's because taking an ethical approval is quite key. You need to train people. That means you are likely to expose multiple people. I mean, maintaining those COVID preventive behaviors, even for the data collection, was quite key. Timely generation of information is quite key throughout the pandemic because you can make your ongoing program quite responsive to the evidence that you are gathering. So what we'd actually use for the second phase of our campaign, we actually use the data coming from this survey is quite helpful. Finally, on the methodology side, building trust while collecting data is important because people are fearing when someone visiting their house, or it might be due to people coming for exposing me with the contamination and so forth. So on the programmatic learning, reach was high. Our intervention was reaching to the many people, and then the reported knowledge and practice was quite high. But the emphasis should be given on the subset of the behavior. For example, just telling wash your hands is not enough. You need to tell specific moments. For example, washing your hands when is specific COVID preventive critical times was quite important. The barriers and motives we have identified throughout the pandemic. There were several, but these surveys actually help us to concentrate on key specific motives that we would like to use beyond fear. That is currently we're using part of the second phase of the response. The touch points through which we are exposing to the people is quite important, but exposing people multiple times with repeated frequency does require a diversity into the touch points. For example, majority of the people were exposed through mass media and social media, television, radio, but people with disability, they were only exposed through local NGOs, newspaper. So we disaggregated data. By looking at this data and diversity in terms of touch points was quite helpful for us to also emphasize which one of those touch points are preferred for different target audience. So with that note, I think I'll sum up here because this is just a part of the presentation, not the full fledged outcome from the midterm rapid assessment. With that note, I really would like to thank the Learning School, RANA's colleagues and WattWord colleagues throughout for supporting this large scale midterm rapid assessment survey. Thanks. Over to you, Arjen.
Thanks. Yeah, very, very thorough initiative, which is great to see. And, an important takeaway here is really the survey design you use and the learnings you shared as you develop those questions to evaluate the COVID behaviors there. So moving on to our last case study, if we could move to the next slide. So next up, we have Aya Hushaimi, a project manager at the Norwegian Refugee Council, who will be presenting on some operational and programmatic adaptation that they did over there. So over to you, Aya.
Hello all, thank you. I will be presenting the operational and programmatic adaptation presented by the Norwegian Refugee Council. Second slide, please. So we are working in Lebanon, targeting 16,000 refugees, approximately 3,200 families living in informal tented settlements in 10 municipalities in Bekaa. During 2020 and 2021, there was multiple COVID-19 lockdown, which affected our operation and the need for adaptation during these periods. The major programmatic work during the pandemic is water tracking increase from 35 liters per day per person to 60 liters per day per person. Addition of COVID-19 prevention and vaccination awareness activities, in addition to the COVID-19 hygiene item distribution, as you saw down, hand washing kits, disinfection kits, menstrual hygiene items, and as well infection prevention control kits for COVID-19 cases. As well, we installed hand washing stations at the entrance of ITSs to promote hand washing. So those activities been adapted based on the needs of the pandemic. Next slide. During the M&E collection of data, we faced some challenges. As mentioned by Seren, there was the COVID-19 lockdown, which make the M&E activities non-essential or not being focused on, rather focusing on the life-saving activities and the services. Focus group discussions, the usual ones we do in person and consultation, are not applicable anymore. There was some of the data regarding wrong or inaccessible phone numbers, especially during the pandemic and the economical situation we face in Lebanon. Some of the phone numbers are not anymore accessible. Observation questions were challenging to be adapted from the observation that is done on site to a phone call questions. Beneficiaries fatigue, because at the beginning of the pandemic, many NGOs were reaching the beneficiaries and asking for the surveys. So it was important to have a collaboration between NGOs in order to decrease this. And this what happened. We will see in the pre-COVID-19 survey, we collaborated with other NGOs to collect data. Some data was not reliable, some of exaggeration of the needs, or some reporting of some behaviors. The example, the behavior of wearing face masks, whereas actually they were not. So it was important to have like verification and cross-checking of data with other resources, and consultation to be ongoing through the intervention. Second slide, please. So in order to like collect the needed data for us for the informative programming, we adapted the M&E modalities. Rather than having the consultation in person, it was done remotely through the phone. We have the advantage of having focal points inside the informal tented settlements, where they are volunteers inside the ITSs. They were we reached them. We did the survey with them, reflecting the needs inside the informal tented settlements. It was very important that we as well continue the monitoring system we have through the COBO system, monitoring the water tracking service, and we have post-distribution monitoring that is ongoing during the service in order to ensure no protection risk, no child labor. The service is being provided to the beneficiaries even during the lockdown. And we did post-distribution monitoring for all our services that was done and activities. And we did CAP survey, which is done on a yearly basis, focusing more on the knowledge, attitude, and practice. It as well covers the COVID-19 intervention and questions. Next slide, please. So, as I mentioned before the intervention of COVID-19, COVID-19 is a new pandemic. It was important to consult the beneficiaries and ask what are their needs, because it was a new pandemic. As well, we collaborated with other NGOs with a consortium regarding the data collection. This widened our accessibility for additional areas and additional beneficiaries. And there was those data was analyzed and shared. Those was the building of our COVID-19 intervention. During the intervention, we were ongoing having a consultation with the beneficiaries, with the focal points. We have WhatsApp groups, so we were able to be in contact with them in a regular ways. The post, and I will be talking more about the post outcome. It was, as I mentioned, done through phone calls. It is a way to report for donors for the outcome, and as well it was checked with other verified with other data. And this was one of the advantage of our presence as NRC for a long period inside the same informal tented settlements. So we have previous data to verify on previous phone calls. So our data collection was easier than other ones who don't have initial data. We targeted the 10 WASH areas for the post outcome. We have 5% margin of error, 95% confidence level. We reached, like 74% of the ones we reached respond, 50% were not reachable through the phone numbers, and 11% didn't give us consent to do the CAP survey. Next slide, please. So the outcome or key findings regarding the CAP survey, knowledge, attitude, practice, the outcome of our WASH intervention and COVID-19 as well intervention. Regarding water, 83% of beneficiaries report using a sufficient amount of water for daily use. This especially that we increased the water tracking from 35 to 60 liters. 95.3% of beneficiaries have zero fecal coliform in drinking water at point of use. Regarding sanitation, 97% have access to household latrines. 3% were still sharing latrines with their neighbors. 81% are satisfied with the design, and 88% are satisfied with the latrine location. Regarding hand washing, 99% wash their hands with soap and water. 82% remember to wash their hands after arriving home, which was one of the key messages regarding COVID-19. And this is why we installed the hand washing stations at the entrance of the ITSs. Additional findings, 93% were satisfied with the hygiene promotion intervention. Refugees' needs for hygiene items were increased, and because of that, in 2021, we increased and we added more dignity kits. This was reflected due to the economical situation and the increase in prices in Lebanon, and as well regarding the COVID-19 situation. Next slide, please. So the last slide regarding what we learned, adaptation of the existing M&E tools to remote one is very important, and the preparedness for the data collection. It doesn't work that you just shift from in-person to the same questionnaire to be used from in-person to a phone call. There is need to adapt this, especially the observation questions are challenging to change. Acceptance of the targeted group. Now, there is more acceptance. At the beginning of the COVID-19, it was new to have such CAP survey or PDM on phone. Now the staff, the beneficiaries themselves get used to such contact. It's very important to do capacity building for the staff using technology as well suppliers, because we do water tracking and sludging through the suppliers and monitoring. The ITS WASH focal points is very important. As I mentioned, we have WhatsApp groups, and as well we do ongoing consultation with them. Ensuring the pre-data collected, as I mentioned, it's very important to have like the refugees data updated regarding phone calls, regarding the ITS location. General principles for the survey and the design: consider availability of tools, especially smartphones and internet. Lebanon, we are struggling now with internet. The survey to be discussed and approved from both program and M&E. This is as well as a lesson learned, especially when you are having enumerators from outside the organization, to have a training before that to explain how to be asked the questions by phone. Analysis of the data would be very useful when you have, like, as well as I mentioned, other data that you verify on it, or you use different modalities for collecting data. And at the end, it's very important to use to take the consent of the beneficiaries, gender, privacy, and people with disability inclusion when doing data collection. Thank you. We will go for questions and answers.
Yes, thanks again. Thanks, Aya. Yeah, really interesting to hear how you were able to adapt your operations and programs, and also a really great example in a humanitarian setting. So this really just showcases the different M&E challenges in specific contexts. Morgan, if you could go to the next slide, we will have time for Q&A now. And again, please use the Q&A function to ask any questions. We have about 25 minutes left, depending on how many come in. And if we don't get to your question during this session, we'll be sure to address it in the follow-up materials. But we do have quite a few questions that have already come in, so I'll go ahead and get to those. So one of the first questions that came in, there are actually a couple that focused on around remote monitoring, particularly through phones, WhatsApp, etc. Can any of you expand on any insights or lessons learned for remote data collection? Are there any tips or guidance on short message service or text messaging for data collection?
I can perhaps expand a little bit on the text message piece, because I think during the early stages of the pandemic, there was quite a lot of organizations who did try as much as possible to contract out some of their M&A. And so we saw quite a few organizations using either the IVR type approach with pre-recorded messages where people give answers by pressing buttons on their mobile phone, or SMS-based questioning. And I think one of the challenges that came out of both of those methods was that you have to be really so limited with the things that you ask. You often are talking about sort of a maximum of about 5 questions. They have word limits. You obviously have to have closed answer or multiple choice answer questions. So whilst it can be a feasible method to do, it is one that didn't necessarily always result in that rich kind of programmatic learning that people were after. But on the upside, it had the ability to reach a large number of people very quickly. So I think, you know, this is one of the limitations that we're working within at the moment. Pretty much irrespective of which method we choose, there's always going to be pros for that method and also limitations. And I often think the key to overcoming some of those limitations is to combine different approaches.
Great, thanks, Sean. And for others, have there been any surprising results from phone-based data collection compared to in-person, or as you've adapted to more remote data collection? Has there been anything surprising that you found as you've adapted your M&E approaches? Anyone want to take that on? If not, we'll move on to the next question. Perhaps we could address that in the follow-up materials and provide some more examples of that. Dennis, there was a couple of questions for you specifically. So there was a person who asked, how were the regions selected in Kenya, and are there plans to assess the harder to reach areas?
So I'll talk about how the regions were selected. So we were implementing a project funded by Unilever and DFID, FCDO now. And we had active implementation across 13 counties out of the 47 in the country. So the 5 were randomly selected out of the 13. And that is what informed the regions that were selected and where the study was undertaken. In regards to the hard to reach areas, we during that time, of course, there were issues around flights that were not available. So when we were doing the selected targeting, those were factors that came into play. But at the moment, we really don't have a lot of plans to expand to those hard to reach areas in the northern part of the country. But we hope that the information that we've collected would mostly inform adaptation that needs to be done in those hard to reach areas. There was a question around, I think, healthcare workers and the adaptation that needs to be done, or monitoring that needs to be done across the health facilities. So there is another study that we are currently almost publishing that looked at some of the adaptations that need to be done across healthcare facilities. And these are it's not part of this research. So most of the hand washing facilities that were distributed in public spaces were just in markets, offices, entrance to offices, maybe bus stations, shopping centers, and the like. So those were just public spaces, but we conducted another research that we are yet to publish. Thank you.
Thanks, Dennis. And actually, while I have you, I'm curious, what were the backroom discussions like where, you know, the M&E approaches, because I know you use some in-person observation as well. How did you decide on sort of the methodology that you used, and how did you consider the safety factors in light of COVID-19 as well?
Yeah, so during that, of course, the NBCC has so many partners. I think there were close to 25 to 28 partners. and each partner were having different way of collecting information. And we thought that those information were a little bit haphazard. They were not as informative. They were not backed by science. So then we thought we had a brief discussion on looking at using sensors, but then the sensors posed some challenges. So because these hand washing stations were mobile, so sometimes they'd be kept in a shop or kept in under a key and lock somewhere in a room, so that it's taken out in the morning and taken out in the evening. So we thought maybe the issues around maybe theft issues for the remote sensors. There were issues around maybe network issues for the remote sensors. So that idea was shelved. Then the other better method was issues around observation. So why not recruit people who are very qualified, give them, train them, and ensure that they can collect data. We did some pilots just to ensure that the data that was coming out was as accurate as possible. And during the data collection, we also had a team moving around, just checking on, also monitoring the enumerators, just to ensure that that information, they were doing as instructed. So we thought observation would give us the best accurate data, because basically it's a person and we have a questionnaire, so you just fill that in. Also, of course, there were issues around the management, the distribution, issues around caretakers. So we thought we also have key informants across the partners, just gaining some insights on what went well, what didn't go right, what needs to be changed here and there, and their recommendations. And that is also captured in the report. And lastly, it was also important to, of course, ask the users their experiences, because we had designed these hand washing stations as also information and communication centers for some of the methodologies to control COVID-19. So basically, how to wash your hands, best techniques, making sure that you wash your hands at certain intervals. So there were also information materials that was put on, that were placed on these hand washing stations. So it was also important for us to really learn to see if what we had theorized was making sense and what needed to be changed. So the report also, of course, clarifies all these issues. It gives some recommendations on how to word your IC materials, the kind of information that needs to be placed there, and the likes. So that's it.
Great, thanks so much, Dennis. Ian, perhaps you could jump in on this next question. What seems to have helped actors share their data with each other and or do joint monitoring together? Both of you talked about working with different partners. Can you go through that question, give some insights there? Go ahead.
Yeah. Thank you very much. It's a good question. I think let's say if you are collecting data from multiple countries, and irrespective whoever implemented the hygiene response, because primarily every organization will focus on their behavior for COVID-19, right? It's the 4 key hygiene behaviors: wearing a mask, physical distancing, hand washing with soap, and frequently cleaning frequently touch surface cleaning, right? So if we have a standard behavior, if multiple partners were gathering the data using the standard tools, I think repeating the same data collection by different partners is not worth it. And if we start sharing the data, the insight coming from one individual organization can actually be applied by other organizations. For example, in 8 countries where we have collected data, we have shared the report with the national government, with the local partners implementing there, right? So they don't need to collect again the same data. I mean, one is one organization leading it, and maybe kind of other supporting it, collecting, sharing that information actually help to improve the ongoing response, not only to the partners, but also to the government as a leader of the response program. Second, if we do a joint monitoring, of course, the data, we can increase the volume of the data. we can cross-fertilize ideas, we can reduce the gap, because if some organization actually collect the data on specific elements, the other organizations don't need to do the same process. And then I think if we cumulatively do the process, it's actually help us to fulfill some of the gap. For example, for our multi-country, the midterm rapid assessment, we have collaborated with Hygiene Hub, WaterAid, and RANAS, because RANAS use a different approach, WaterAid use a BCD, and working with academic institutions like London School of Hygiene and Tropical Medicine, we actually started looking, let's standardize the tools, right? Let's have a module-based tool, so that these are the essential ingredients of the information we need in order for us to subsequently look the intervention. What are the gaps? Whether our intervention is effective in terms of motivations, what are the barriers, the behaviors, the social norms around. If we merge that, I think it would be always nice to have those standard outcomes, so that we can cross compare, share. Other don't need to repeat the same. And the data coming from, in particular, from the hand washing facilities, public hand washing facilities, might be also helpful for the GMP, for example. So we have collected massive data from WaterAid. The colleagues Dennis mentioned, he has collected those data from Kenya, for example. Is that the data coming from the government for the GMP, how some of the data for the public hand washing facility wasn't there. Maybe this will also fulfill the gap for the sectoral monitoring aspects. I think there are lots of advantages if we kind of cross your ideas and also jointly do the monitoring and share the data.
Yeah, that's really great. Yeah, I mean, see quite a few more questions coming in, so we'll try and get through all of them. But again, if we can't, then we'll be sure to address them in the follow-up materials. So the next question here is, do any of you have any insights on overcoming challenges in languages, cost of technologies after the sudden change in M&E approaches due to COVID? As well as data safety and using some of the online platforms. Any insights on overcoming any of those challenges?
I'm happy to speak to that if no one else has some kind of concrete challenges or concrete perspectives. I think in terms of data sharing, that's actually something that I think is a really important point. So thanks to the person who raised that. It's come up a lot more during the pandemic, I think, because typically we may have worked in a world where we collected the data on site, it was analyzed on site, and then it influenced programming right then and there. But I think the pandemic has allowed us to, or encouraged us to share a lot more internationally in terms of data sets and things like that. So I have seen a lot of organizations kind of tighten up on some of their data sharing regulations and coming up with data sharing agreements if they're entering into partnerships like the one that described. So I know the Hygiene Hub, for example, has supported on secondary data analysis for several organizations, but always we're putting together a quite detailed data sharing agreement to facilitate that process. So that's one comment. I see that Aya also has some thoughts in terms of that question, so I'll hand over to her.
Go ahead,
Thank
Aya.
you. Yeah, one of the lesson learned regarding the WhatsApp messaging is instead of having text, having voice messages done by the staff, and having it sent in a short time, and using that as different timelines, not having the same messages to be sent on the same day, many of the messages at the same time. So rather having a plan through a weekly basis to send an update or a COVID-19 message or a reminder, as well having someone who is inside the location you as a focal point, or someone to disseminate this would as well decrease the beneficiaries' fatigue regarding the WhatsApp messages taken from different NGOs. Over.
Yeah, great. Thanks, Aya. Moving into a more general question too, can all of you speak more on the approaches for measuring acceptability and sustainability? Just really getting more into sort of those impacts there. Or if you could get into sort of the M&E approaches that you use to measure acceptability and sustainability through your programs.
I don't know, Dennis, did you want to start on that? Because I know it's something that you've thought about quite a lot in terms of hand washing facilities.
Yeah, thanks, Ian. So in regards to measures around sustainability, there are issues around management. I think it's really important to ensure that the hand washing stations around public spaces, the considerations around the overall management of the hand washing stations is very, very important, because this ensures that over time, the hand washing stations, the taps are working, there's water and there is soap over these times. We also realize that, for example, if you have, like in Kenya, where you have a campaign that looks at ensuring that in any public spaces, either entry or exit in these public spaces, there are hand washing stations, and it is by law or by regulation that you must wash your hands as you enter, you exit public spaces. So these automatically translated to these public spaces, shops, supermarkets, market spaces, having people having caretakers, or people who are manning these hand washing stations. So they acted as monitors to basically ensure that that regulation is enforced. So when you have such a caretaker, one, they'll ensure that people wash their hands in a proper technique. Secondly, is that you'd find that all the commodities are replenished whenever necessary or whenever needed. The other bit I think that also helped us was the fact that there was a national campaign encouraging people to wash their hands, and these public hand washing stations acted as queues. So whenever they are placed in a location that you can easily visualize, of course the height is proper, the issues around drainage is also considered, then people would wash their hands. So again, to mention a factor around drainages, you'd find that people mention that whenever the drainage was poor, so meaning that once you wash your hand, then basically there'll be water that will splash towards you. Then that factor also was a barrier towards washing their hands. So when we encourage our partners to basically ensure that this is also considered, so that people would also be encouraged to wash their hands. So there are, of course, I already mentioned issues around disabilities. That is a factor that should be considered. And also the fact that over time we changed the kind of taps so that you can use foot pedals. So those are some of the measures that we thought would encourage sustainability. Thank you.
Great, thanks a lot, Dennis. It seems like we only have time for one more question, but again, we'll be sure to address all of the questions that we weren't able to get to in the follow-up materials. But really throughout this webinar, we've been talking about this learning brief and translating these learnings. How can we improve the process of translating learnings into programmatic actions? Does anyone have any final thoughts there?
I think I can come here, Aryan. So I think collecting data is one thing. Whether or not organizations actually use them in order to inform the ongoing response is quite key. For example, in WaterAid, when we have done the rapid assessment in 8 countries, because we were collecting data while running the program, we didn't pause anything as we are collecting the data, but it was quite a bit of kind of, the information coming from the midterm rapid event for us to think where we should focus the ongoing campaign in the second phase of our response. So you actually need to utilize, need to find a time to really look whether or not your existing campaign is responding to the data that you are getting, right? So it's useful. I think those information is actually useful. You need to find a way of pausing it, reflecting it, and if needed, maybe tweaking it. You cannot completely change the horde modality, because that might have an implication in terms of the how you ensure your fidelity of your campaign. But at the same time, if things are not going in the right direction, it is important that you focus on those, right? That's for the behaviors and elements. Which motives we are going to focus, what's barrier we are going to address, which is specific subset or subset of the behavior that we are going to focus. Similar to the functionality of the hand washing facilities in public places, we have done exactly the same what Dennis mentioned. But what is important for us to look, is there an institutional mechanism to continuously monitor those the hand washing facility over time? Is there an operation and maintenance plan on a daily basis? Who is operating on a daily basis? Because does need to refill the water, does need to refill the soap, right? If those are not there, it's not going to functional. And then at the same time, the visual cues, nudges, and reminders need to be in place all the time. Otherwise, people may skip, right? So I think some of these aspects is actually ensure the sustainability aspects. If those are not reapply into the programming, then those data is not going to be useful for our future programming. So finding a time to reflect, look the existing programming, and really address some of the learning coming from the evidence is quite key. Aaron, just one point, since as I'm here, I think there was 2 questions on what was the benefit of standardizing the tools and methods. Very briefly, I've responded it into the chat box, but very briefly, because many country program this time or during that time are responding to the COVID. They are busy, quite busy in terms of responding it, rather than monitoring and making sure they don't have time. So when you do the standardization process, what happens? It is actually facilitate countries to contextualize the tools. When you standardize, you are looking different aspects of the areas where information you want to collect. You want to standardize different segment of the behavioral elements where you want to extract the data. The standardization process also help country to actually standardize their training package. You can standardize training so that that training can be cascaded to the data collectors. When you standardize it, also you can also standardize the data analysis process so that you can cross compare the data by different countries. You can also generalize what are the common determinants all across threats, so that based on that you can actually use some of the common determinants part of your package, because you cannot address every details of there. So yeah, the standardization has a lots of advantage. The limitation there would be sometimes you need to find a way of contextualizing. Standardization was a similar level of, for example, socio-demographic characteristics may not be relevant in Asian and African context for some variables. So you need to find giving that flexibility. But if you standardize, at least during emergency time, it helps country to kind of be more efficient and focusing on the core function rather than kind of distracting themselves from the implementation, because implementation was the heart of the COVID response throughout the pandemic. Thank you.
Yeah, no, thanks for that. I certainly agree with that. I know we're just at about time here, but again, I know that there's lots of really great insights coming into the chat now, and still a lot of really interesting questions that we'll hope to address as well. I'd like to thank all of our speakers and the co-conveners at the COVID-19 Hygiene Hub, the Global Wash Cluster, and the Global Hand Washing Partnership for just making this webinar possible. Again, the full brief is now available on the Hygiene Hub's website. And Morgan, if you could actually just change to the next slide quickly. That is the Hygiene Hub website. We also encourage you to use other resources from the Hygiene Hub. And again, a link to both the Hygiene Hub M&E resources and the learning brief were posted in the chat earlier, and the website is on the screen now. Follow-up materials will be available in the coming days, so please do share those with your organization or networks. And again, thank you to everyone for joining this important webinar on monitoring and evaluation. We look forward to continuing to collaborate, share, and learn from each other. So thanks, everyone.